Ladies and gentlemen, welcome to the World Sepsis Day 2023 webinar, titled Challenges and Priorities in Sepsis. We are delighted to have you join us for this important event. Today, our webinar is hosted by CCNAPI in collaboration with WFCCN, bringing together experts and enthusiasts from around the globe to discuss critical topics in sepsis management. We hope you'll actively participate by asking questions and engaging in discussions throughout the event. Together, we can work towards a better understanding of sepsis and its management. Good morning, ladies and gentlemen. I am John Kevin Fair, a clinical nurse educator at Makati Life Medical Center. I am honored to be your moderator for today's webinar. Okay. Ladies and gentlemen, distinguished guests, and fellow healthcare professionals, let us hear the opening message from President of World Federation Critical Care Nurses, Adriano Friganovic.
Hello everyone. On behalf of the World Federation of Critical Care Nurses, I welcome you to this important gathering, World Sepsis Day in the year of 2023. It's my privilege to see such a diverse and dedicated group of individuals here today, and all united by a common goal, raising awareness about sepsis and working together to combat this global health crisis. Sepsis remains a silent, deadly threat, claiming millions of lives worldwide each year. It knows no boundaries, affecting people of all ages and backgrounds. However, our collective determination of knowledge and actions can make a profound difference. Today, at the World Sepsis Day, we must remember that knowledge is power. Through education and awareness, we can empower ourselves and others to recognize signs of sepsis, seek timely medical attentions, and save lives. Sepsis remains a major global health threat and a leading cause of death, disability, and healthcare spending around the world, accounting for about 20% or 1 in every 5 deaths. Sepsis affects 48.9 million people and claimed 11 million lives of children and adults only in 2017. Sepsis-related deaths might be even higher, up to almost 14 million, based on the global burden of disease study, estimating that 7.7 million deaths associated with 33 bacterial pathogens would rank as the second leading cause of death globally in 2019. 15.8 million sepsis cases and 5.11 million, or nearly half of all sepsis-related deaths, occurred in the individuals with underlying injuries or non-communicable disease. Because of all these facts, World Federation of Critical Care Nurses yesterday signed the Berlin Declaration of Sepsis. We want to fight together to prevent this global problem. I want to express my gratitude to all of this organization, to healthcare providers, researchers, and individuals who are dedicated to this cause. Your tireless effort and making a difference, we can continue to raise awareness, improve sepsis cares, and save lives. I want to thank to Bel Rogado and Filipino Critical Care Organization, and to all participants, I wish successful event. Thank you very much.
Thank you, President Friganovic, for your inspiring words. Let's proceed with the first topic for today's webinar. Let me introduce first our speaker. Let me read the webinar. So this webinar is about 4-hour learning program aims to explore common challenges in recognition and management of sepsis. In addition, this activity intends to provide the nurse attendees with up-to-date guidelines and evidence-based practices in the care of patients who are at risk of developing sepsis and the impact of early recognition in the management of the disease. This activity is celebrating the World Sepsis Day, which is held every September 13th. It aims to provide an opportunity for people worldwide to unite in the fight against sepsis. Sepsis accounts for at least 11 million deaths worldwide annually. Yet, depending on the country and education, sepsis is only known to 7 to 50% of the people. Likewise, it is poorly that known that sepsis can be prevented by vaccinations and clean care, and that early recognition and treatment reduces its mortality by 50%. This lack of knowledge makes sepsis the number one preventable cause of death worldwide. So this program specifically aims to, number one, to discuss and differentiate the various internationally recognized tools in detecting sepsis. Second would be present management and treatment of sepsis based on the recommendations made by surviving sepsis guidelines. Provide an approach in handling patients diagnosed with sepsis in systematized manner. Highlight the roles of nurses in sepsis management. Fifth would be recommend methods in maintaining efficiency and competency of nurses in recognizing sepsis. Sixth would be to apply the best practices that will inspire nurses to perform the routine assessment in sepsis. So this webinar is applied for CPD units to the PRC Board of Nursing. However, the status is still pending, but the technical team will update you once it's accepted. Okay, so let's proceed with the topic one. First, let me introduce our esteemed guest for. Ladies and gentlemen, it is my honor to introduce Professor Laura Alberto, an influential figure in nursing and critical care. She joins us today on World Sepsis Day 2023 to discuss priorities in sepsis management. Dr. Laura Alberto, an indigenous nurse from Argentina, is currently a professor of nursing at the Universidad del Salvador in Buenos Aires. Her notable achievement includes pioneering an intensive care unit liaison nurse program in Argentina, elevating critical care in the country. Her research expertise spans critical care practice, sepsis recognition, and sepsis recovery, including the challenging aspect of long COVID-19. Laura has held significant roles within the World Federation of Critical Care Nurses since 2003. She led the formation of the Latin American Federation of Intensive Care Nurses in 2006, now a vital part of WFCCN. Dr. Laura Alberto is Associate Researcher at the National Scientific and Technical Research Council, or CONICET, Instituto for Research in Medicine and Health Sciences. Professor Laura is a prolific author with numerous peer-reviewed publications on sepsis and critical care nursing. She's also a renowned international speaker and contributor to editorial boards. Laura's dedication has earned her prestigious awards such as the 2012 Endeavor Research Fellowship and recognition for her role in forming the Latin American Federation in Intensive Care Nurses in 2007. Her educational journey includes a Bachelor of Science in Nursing and Master's in Education with specialization in Educational Management from Spain. She is also a certified communicator of science. Her international expertise includes research roles in Argentina and Australia. Laura's commitment to quality and research nursing evident in her contributions to the Sanatorio del Alta Complejidad Sagrado Corazon in Buenos Aires. Recognizing her contributions, Professor Laura Alberto has been an honorary ambassador of the World Federation of Critical Care Nurses since 2014. Today, we are privileged to hear from Professor Laura Alberto, who will share her insights on priorities in sepsis management. Her extensive knowledge and dedication to the critical care have made her a global leader in nursing. Please join me in welcoming Professor Laura Alberto. Dr. Laura Alberto, the virtual stage is yours, and we look forward to the invaluable insights you are about to share with us.
Thank you very much for this kind introduction. I am delighted to be here. I will share my presentation. And I will play the record, and I will back leave for the questions time. Thank you very much. Delighted to be here. Here it goes. Good morning, good afternoon, or good evening, everyone. Thank you for inviting me to share with you the World Sepsis Day. I am delighted to talk about priorities in sepsis management. I will talk about tools to detect sepsis and priorities on sepsis care, referring to the Surviving Sepsis campaign guidelines. I have no conflict of interest to declare in relation to this presentation. Today's presentation, I will share some concepts, some background to understand sepsis as a global problem. Then I will talk extensively on evidence, on tools to identify sepsis. Then I will share with you a study on testing and implementing a screening tool that I think is very, it's important to discuss some implementation aspects of screening tools. And the last section of this presentation, I will talk about priorities for the early recognition and treatment, referring to the Surviving Sepsis campaign guidelines. So let's go to the background. Sepsis is a dysregulated host response to an infection source and a global health concern. Every year, almost 50 million people are affected, and among them, 11 million will die. They represent 20% of the global deaths. Sepsis mortality varies greatly across the world, with over 20% in Australia to over 50% in Brazil, and with great variation across settings. Historically, sepsis patients were admitted into intensive care. However, there are now patients, more sepsis patients being identified in hospital wards. The rate, they represent 7% to 80% of sepsis cases in the wards in different settings. Sepsis patients are prone to clinical deterioration and rapid response activation. Sepsis is the second reason of rapid response activation, and among those patients who activate rapid response systems, 1 in 3 will die. Sepsis is a complex condition. Sepsis cost of care and mortality is greater in those patients who are diagnosed with sepsis while hospitalized. And sepsis mortality and cost of care is less when the sepsis patients are diagnosed at admission. Probably this may be related because of the resources where the sepsis patients are cared. Emergency departments have different clinical and other resources different to the hospital wards, for instance. Sepsis patients require intensive care. 1 in 3 patients admitted to intensive care have sepsis. Intensive care is an expensive care. A study from the US context highlighted that intensive care cost was 4% of the national health expenditure, and that was equivalent to 0.6 of the gross domestic product, which means if 1/3 of intensive care patients is having sepsis, 1/3 of this cost is dedicated to a complex sepsis care in hospitals. That is not the end of the story. Patients who survive sepsis suffer reduced independence. They report anxiety, PTSD, and loss of limbs. And some, 1 in 5 survivors will die within the 2 years of hospital discharge. And this is likely because sepsis has changed the microbiome and has affected the immune system, what makes the patients prone to new infections and new readmissions. So that is, this evidence is telling us that sepsis is a global health concern that also has lasting consequences. That is so important to identify sepsis early as possible. So sepsis is a complex problem, and tools to detect sepsis, screening tools, or tools that help us identify as early as possible this condition are so important. But before going to the evidence, I would like to share some concepts that are relevant. Let's think a bit about tools and diagnosis. Tools to screen for sepsis. A screening tool, which is a set of variables that we use to assess the patient. And in assessing the patients, we can see if we see early signs and symptoms of sepsis. So we are using, in this case, a screening tool. And the screening tool may be positive or negative, depending on how we define, how we choose these variables, and we define when the tool is positive or negative based on the evidence available. So let's say the screening tool may be positive or may be negative. So if the screening tool I am using to assess the patient allows me, and I reach the conclusion that the patient is developing sepsis using the screening tool, will the patient actually be diagnosed with sepsis? Is the patient actually developing sepsis? Screening tools are tools that help us the assessment of early signs and symptoms. And these signs and symptoms can be similar to those signs and symptoms of other conditions. And sometimes the diagnosis of sepsis is retrospective. That is why it's so challenging to recognize sepsis very early. Also, there is no reference standard for the diagnosis of sepsis. It is a syndrome with a constellation of signs and symptoms. And the diagnosis of sepsis, according to the latest definition of sepsis, includes the presence of infection, confirmed or suspected, plus the SOFA score, 2 points of the SOFA score that is indicating organ failure. And we have to suspect that organ failure is caused by the body's response to the infection. But this diagnostic process takes a while, and it's not immediate, because organs can be failing, and we have several organs, and we also need to confirm the infection, and sometimes the infection is suspected, and the cultures take a time. So the diagnosis of sepsis, to confirm the diagnosis, take a while. So that is why the tools to recognize sepsis, these clinical criteria, the screening tools can provide, are so important. But it is important to say, if there is no reference standard for the diagnosis of sepsis, that's make it more challenging. I mean, the diagnosis is more challenging, and screening and assessment so important. So What concepts I would like to visit before presenting the evidence? These are concepts, statistical concepts that are usually used in public health and in studies on screening and diagnostic tools for sepsis. And these concepts are sensitivity and specificity. Sensitivity is the true positive rate and allows us to understand how well a test can identify the true positives. Let's say we have a screening tool, and this screening tool, we determine a threshold of this scoring tool, and we say above of this score, the patient is highly likely to have sepsis because the patient met the criteria we have set for that screening tool. So then we have to see the diagnosis of sepsis. So if those who were screened positive, they are actually diagnosed with sepsis, then we can say the tool is sensitive because it is screened positive and the diagnosis was later confirmed. And specificity is the true negative rate. Similarly, it allows us to identify those true negatives. If the patient screened negative, we will rule out the diagnosis of sepsis because the patient will not develop sepsis. Sensitivity and specificity are characteristics of the tool, of a screening tool, and they are used to examine binary tests. That is, the screening is positive or negative. And we compare that screening positive or negative against the diagnosis of sepsis, that we consider the reference standard. As sepsis do not have a reference standard, I'm sorry, I apologize because of my English. And so we have to define what criteria we use for the diagnosis of sepsis. And currently that is sepsis 3, the latest definition of sepsis that was published in 2016. So let's continue with another concept, a couple of concepts more. And the second concept I would like to visit is the area under the receiving operating characteristics curve. And this is another statistical test that allows us to relate the sensitivity and the specificity of a given scoring tool. Specifically, it helps us relate the sensitivity versus 1 minus specificity. The different cut points on the curve correspond to the different cut points used to determine whether the test results are positive. The area under the receiving operating characteristics curve refers to the ability of the scoring tool to discriminate those having a given outcome or diagnosis at a defined cut point. This statistical test is usually used in scoring non-binary tools. So those we have several values, let's say, scoring or degrees, non-binary screening tools. The other concept that I think it's important to consider is the predictive values. In real-world practice, it is often more meaningful to predict whether a particular person will truly have the disease based on a positive or negative screen result. Predictive values reflect the proportion of positive and negative results that are true positives and true negatives. Predictive values are statistical tests that allows us to answer the question, if I have a positive test, what is the probability that I actually have the disease? Conversely, if I have a negative test, or let's say a negative screening test, result of the application of a screening tool, what is the probability that our patient actually do not have sepsis? I think these are important concepts that we need to understand to help us understand how the screening tools to identify sepsis perform. And I share this because I think it will help us to understand the evidence that we'll provide later on in this presentation. So let's continue. Let's continue. So having said, having these concepts on statistics, let's have a look at the evidence to inform sepsis screening. In the first year of my doctoral studies, I conducted a systematic review revisiting the evidence of over 25 years on screening tools in hospital ward population, and I found only a handful of studies referring to screening tools that were electronic tools and paper-based tools, nurse-led screening procedures. The sensitivity and specificity varied, and a few, when used, resulted in significant changes in the provision of treatment and decreased mortality. There were limited information on the implementation, and all of the studies were from the USA. A few years later, I updated that review and found that there were more studies beyond the USA. There were in North Europe and Asia, in China. Sensitivities and specificity of the tools varied. One study showed no difference when implemented, and another study highlighted better observation of vital signs, fluid administration, and increased 30-day survival. There was another secondary analysis of data from 9 low and middle income countries that was published after 2016, after the sepsis was redefined. And this secondary analysis referred to the score that was developed with sepsis 3, the QSOFA. A QSOFA, or quick SOFA, is the quick sepsis-related organ failure assessment. It is a 3-variable score, and that was developed based on the examination of large data sets of patients with infection. These 3 variables are respiratory rate, systolic blood pressure, and altered mentation. And this score was found that was associated, QSOFA positive was associated with increased risk of death in patients with infection. And the predictive validity represented by the area under the receiving operating characteristics curve was 0.7 for mortality, for the prediction of mortality. So this is a very, one of the first studies, secondary analysis, but one of the first studies examining the predictive validity of this score in low and middle income countries. So let's visit another other studies. The Center for Disease Control and Prevention released the adult sepsis event surveillance definition that includes simplified organ dysfunction criteria adjusted for electronic health records, and they named it ESOFA. This is a study by Ree and colleagues who compared the ESOFA versus the sequential organ failure assessment with regards to sepsis prevalence and other outcomes. This was a study with a retrospective design and in 111 hospitals in the USA. Let's see what is this simplified ESOFA, which is an electronic surveillance tool for sepsis. So the researchers utilize the SOFA score as a framework, and they have developed for each of one of the SOFA criteria, one ESOFA criteria, a binary one for most of the organs. For instance, for cardiovascular, the binary ESOFA value was initiation of vasopressors. For respiratory, the initiation of mechanical ventilation. So for renal, hepatic, and coagulation, there were laboratory parameters. And for neurological assessment, this component was not included in the ESOFA. Instead, they have used the Glasgow Coma Scale. They did not use the Glasgow Coma Scale, I'm sorry. They have used the lactate. Glasgow Coma Scale have some limitations for surveillance because they depend on the clinician practices, assessment practices, and documentation practices, whereas the lactate values can be retrieved directly from the laboratory findings. And this ESOFA has been examined, and let's see how this early electronic surveillance tool performs. And we'll see here sensitivity and positive predictive values for the evaluation of the performance of this surveillance tool. Relative to sepsis 3, which means sepsis 3 considered as a reference standard as the diagnosis of sepsis, the ESOFA sensitivity is almost 60%, and the positive predictive value is over 80%, which is a very, very good positive predictive value, although the sensitivity is modest. But the clinical utility having that good positive predictive value is very good. And as you can see, the researchers have examined the sensitivity and positive predictive values for different subgroup of patients. And the sensitivities are a bit modest, but are between 54% in those with low comorbidity burden to 72% for those with infection diagnosis, intra-abdominal infection diagnosis. And the positive predictive values are over 75%, 80%, which is a very good positive predictive value. So the question is ESOFA recommended? Well, the ESOFA criteria help to identify a smaller, more severely ill cohort of sepsis patients, and that is determined by the modest sensitivity compared with those identified using the more complex SOFA score. These findings support the use of adult sepsis event as a practical tool that hospitals and public health agencies can consider if they want to use a consistent and automatable surveillance mechanism for sepsis. And that recommendation is based on the high and the elevated positive predictive value. But this tool is a very sophisticated tool and needs technology development and IT support in a setting to be implemented, and it's actually and it's needs a lot of resources. Let's revisit another piece of evidence on this. Is an integrative review conducted with a systematic review method by Kumar and colleagues, published this year in Australian Critical Care. The reviewers have examined several triggers and tools. They were based on the Sears criteria. We know the Sears criteria. And they were also triggers based on the QSOFA score. There were other using QSOFA score plus lactate, and there were the MUSE and the NEWS, which are those scoring early warning scoring tools that come from the rapid response science or the medical emergency teams science. Other tools that included Robson and modified Robson, BAS, and other Swedish sepsis tools, including systolic blood pressure lower than 90. In addition, they also found lactate and other biomarkers and electronic health record algorithms that were included as well as triggers. That's a very, very comprehensive review. The tools that were most examined, most evaluated were the SIRS and the QSOFA. And there were the other tools, and this plot shows which tools were compared against which ones. And SIRS and QSOFA are the most examined. And how these tools perform. The median sensitivity and specificity to identify sepsis, that means to diagnose sepsis, were in 11 studies, the median sensitivity was 51% to 82%. And in 12 studies on QSOFA, the median sensitivity was 28% and the specificity was 98%. When QSOFA and SIRS were compared, SIRS was consistently more sensitive but less specific, which means that there were an important proportion of patients that did not develop sepsis, and that they were false positives, that were more sensitivity. They were more sensitive. And there is evidence on SIRS highlighting that higher sensitivity with a considerable proportion of false positives, and but less specific than QSOFA. And QSOFA is more specific and is very good to rule out sepsis. Among other tools, sensitivity and specificity for the detection of sepsis was 84 sensitivity, 84%, and for 85 specificity in 4 studies, which assessed the NEWS. The NEWS, one of the more robust trigger tools for clinical deterioration outside intensive care. And the other tools, one study reported a sensitivity of 92% for the NEWS to predict mortality and ICU admission, Mortality and ICU admission are other outcomes used to examine screening tools, because mortality and ICU admission are a surrogate of surrogate of sepsis, because there are poor outcomes. As sepsis patients develop poor outcomes, mortality and ICU admission are usually examined with the diagnosis of sepsis. And the other tools, which were assessed in 2 and 3 studies, were predominantly conducted in the pre-hospital setting. Their diagnostic accuracy parameters showed considerable variation for both the sepsis diagnosis and mortality and ICU stay. Ease of implementation was assessed only for QSOFA, not for other sepsis triggers and tools. The others I will show you in the second part of the presentation what are the variables of the other triggers and tools, and so we will see how complex they are. QSOFA is a 3-variable score, and it's easy to use. The level and quality of evidence was high for SIRS, QSOFA, the news, and the Muse. But there are more in this review. Okay, I'm there. There were studies on lactate. 3 studies used serum lactate of 2 millimoles per liter and reported a sensitivity of 54% and 95% specificity. Sorry, a range of sensitivity between 54 and 95, and a specificity between 11% to 76%. As there is a great variation in these sensitivities and specificities. One study with a 2 millimoles per liter threshold reported a sensitivity and a specificity of 67% and 47% respectively to identify sepsis. Point of care lactate of 2 millimoles per liter was examined in 7 studies. Sensitivity to identify sepsis range from 7 to 81%, which is a great variation, with a specificity ranging from 42 to 98. Lactate is a biomarker that is indicating cellular suffering and hypoperfusion. And lactate is elevated not only in sepsis patients, but also in other conditions. So it is important when looking at lactate to think about what are the other reasons for lactate being elevated. But every time we see lactate elevated, that is a biomarker that is indicating the patient will have poor outcomes. 10 studies reported that lactate was also able to predict process outcomes, which is the time to antibiotics and diagnosis, patient outcomes, mortality, and length of hospital stay. So lactate is a biomarker indicating always severity. Overall, the level of evidence for lactate was strong. So reviewers also have revised studies on electronic health record-based alerts, and they have found 35 studies, of which most were in the acute care. There were found medium to high sensitivity and specificity. There were great variations in between alerts and algorithms. The overall level of evidence was strong in the adult population. So let's see what the reviewers have concluded after these findings. No single sepsis tool or trigger can be applied across various populations and settings. There is evidence to support the use of the LQ-SOFA as a sepsis screening tool for adult patients presenting to the emergency department and within acute care setting. Q-SOFA had modest sensitivity, and lactate as a biomarker of indicating poor outcomes could be a very good variable to include in the screening tools and highly likely to increase sensitivity of the Q-SOFA score. The news showed best diagnostic ability, that is one of the most investigated scoring tools, particularly from the clinical deterioration science, but it is complex. The implementation might be complex. The automated alert system embedded within electronic health records is likely to be a viable alternative to identify patients deteriorating from sepsis in the acute care setting in the near future. That is, if that resources are available. If the electronic health records and the technology required to implement these electronic surveillance mechanisms is available, that could be the near future. But I tend always to think that that technology is slow to emerge in less resource settings, so in low and middle income countries, where the most burden of sepsis resides. Well, that's a personal view, given the evidence that I am looking at. So how about the implementation of a screening tool? I want to share with you the findings, my doctoral dissertation that was related to the sepsis screening in general hospitalized patients in a developing nation health setting. This was a work, a 4-year work. I will try to summarize the main concepts here, the aims and outcomes of this study that I've conducted at Griffith University, but I collected data in my country, in Argentina. I stayed in Griffith University in Australia, Southeast Queensland. I was supported by scholarships for international students. I was there in Australia for 1 year, conducting the systematic review and planning the study and data collection. And then I came to my country 1 year. I was working in an acute care hospital, working an entire year, collecting data and implementing the tool. And then I went back again to finish data analysis. So I will share with you that process. That was a very interesting, and I have enjoyed doing this. The aim of my study was to implement and test a sepsis screening tool and associated guidelines for early sepsis care in general hospitalized patients in a developing nation, Argentina. Specific aims were to evaluate the diagnostic accuracy of the screening tool, to examine whether the use of the screening tool and associated guidelines for early sepsis care results in improved implementation of the 6-hour bundle. And secondary aims were to describe contextual barriers and facilitators to the implementation of the screening tool and guidelines for early sepsis care, and to develop implementation strategies informed by the barriers and facilitators identified. The outcomes where the primary outcome was the accuracy of sepsis diagnosis, the timing of implementation of the 6-hour bundle, and 6 secondary outcomes were to assess the adoption of the screening tool, defined as the percentage of screenings completed during patient's hospitalization, the time to sepsis alert activation, and the documentation of the screening variables in the health records. And the secondary outcome was the adherence to the 6-hour bundle of sepsis care. The method I have used has been was a combined methodology. I combined a clinical component, which was the interrupted time series design that included data collection prior the introduction of the intervention, which was a 12-week period, and then another 12-week of intervention, and an implementation component which was informed by Parish framework, which is a theory from the implementation science. I'm not going to talk about that theory. I just want to say that the implementation component was informed by implementation theory and had 3 stages. The first stage that was to understand the context and planning the introduction of the intervention. The second stage consisted of education activities to introduce the intervention, and then a third stage where the intervention was live, and I was conducting audit and feedback, supporting staff, so they could conduct the assessments, use the screening tools, and the response to positive screening that was the 6-hour bundle. This has been done in 5 hospital wards in Buenos Aires. The target sample were 1,248 patients. Adult patients were included, recruited within 24 to 48 hours of hospital admission. We excluded patients in the emergency department, intensive care, pediatric, chemotherapy, immunocompromised patients, and those who were already diagnosed with sepsis. The study had ethical approval granted in Australia and Argentina. The intervention consisted of the screening for sepsis and treatment and care. The screening tool was based on the Q-SOFA score and the presence of confirmed or suspected infection. The response to a positive screening was the provision of the 6-hour bundle of care. And the third step was part of the monitoring care, but no data was collected on this step. Nurses were responsible to screen and alert, and the physicians were responsible to evaluate the patient and provide the treatment. Well, let's go to the findings. There I am. And the entire cohort, including the baseline and the intervention periods, there were 1,151 patients that were screened. Most of these patients, a small number of patients were diagnosed with sepsis. The diagnosis of sepsis was conducted by an experienced intensivist who was blinded to the screening variables. And the criteria we used to diagnose these patients was the latest definition of sepsis, which was sepsis 3. And that is why we think the proportion of patients was a bit low, because with using the other definitions that includes the 2001 definition or the bone definitions that includes the serious criteria plus infection, it is probably we would have a greater number of patients with sepsis. But in this cohort, the sepsis patients, which were a small number, sepsis patients were older, had more comorbidities, and stay in hospital longer. We couldn't assess mortality because of the small number of patients with sepsis. But let's see what happened with the screening variables. Of those, of over 1,000 patients, those who met the screening criteria, which were those who had QSOFA positive, were over 200 patients, 213 specifically. I collected independently the QSOFA variables and the infection variables in the entire cohort of patients. That was, and during the whole hospitalizations, which means if a patient was admitted for 3 days, the patients were assessed 3 times a day in the hospital ward, and by 3 days there were 9 moments in which patients had vital signs assessed, and I collected the QSOFA variables of the entire hospitalization. So if the patient was longer, of course, I included all. And the very first QSOFA score was included in this figure. And for having for building, integrating the QSOFA score with the infection variable, I measured those patients who had confirmed or suspected infection or antibiotics administered. If those patients that were having antibiotic administered, I also considered them as the clinicians were suspecting an infection. And there were over almost 600 patients with confirmed or suspected infection, and 213 patients who had the very first QSOFA positive with 2 or more points, and there were 145 patients who met both the QSOFA positive and the suspicion of infection, and therefore they met the screening criteria. And let's have this number in mind to see and to think a bit on the primary outcome, that was the diagnostic accuracy. The diagnostic accuracy was evaluated using the 2x2 table, which is the procedure that allows us to arrive and to assess what was the sensitivity and specificity of this sample. The QSOFA-based sepsis screening tool, we know there were 145 patients who met the screening criteria, which means they screened positive using the screening tool. They had 2 or more QSOFA points plus confirmed or suspected infection. But among those patients, only 28 patients were diagnosed with sepsis with reference to the sepsis 3 criteria. The remaining patients, over 117 patients, met the screening criteria, but they did not develop sepsis. And there were some patients, these 19 patients, who screened positive for sepsis. They had infection confirmed or suspected and had 2 or more QSOFA points, but they did not develop sepsis. This allows us to calculate the sensitivity, specificity, and predictive values. This represents a sensitivity of 60%, similar to the ESOFA sensitivity, and a specificity of 89%, which is quite a good specificity. And a positive predictive value a bit low of almost 20%, and a very high negative predictive value. But when we assess and we relate the sensitivity and 1 minus a specificity using the statistical test of the area under the receiving operating characteristics curve, I found that the predictive validity of the QSOFA score actually was quite good for the prediction of the diagnosis of sepsis, which means the QSOFA score helps the diagnosis of sepsis, and I think this is because of that characteristics of this screening tool, which is the high specificity. And let's see what happened with the other primary outcome. The other primary outcome was the timing of implementation of the 6-hour bundle element, and any element implemented first. And this was measured in 2 groups of patients using Kaplan-Meier analysis or time to event analysis. The figure 8, displays the time to the first element of the bundle implemented in patients who met the criteria of the QSOFA-based sepsis screening tool during baseline and intervention. The median time improved from 22 hours to 8 hours during the intervention period. However, this was not statistically significant. In the second group of patients, which were those who were actually diagnosed with sepsis, which is the figure V, the first element of the bundle during the intervention was implemented at a median of 12 hours, and during the intervention, this improved to a median of 5 hours. Again, this was not statistically significant, but it was within the target time we had, that was the 6 hours, representing the 6-hour bundle. Excuse me. Let's see how the other secondary outcomes were evaluated. I'm sorry, I'm just clicking next. Okay, I'm here. The other secondary outcome was related to the adoption of the screening tools by nurses and measured by the percentage of screening procedures. And the screening procedures conducted by nurses stayed stable during the 12 weeks of the intervention period. And nurses had screened the patients, assessed the patient using the screening tool in 7 out of 10 times. So the procedures were completed at a median of 70% of the possible times, which is actually quite good for a very short period of time the study took. But the other outcomes were not as good. That is the time to sepsis alert activation. During the intervention period, there were over 506 patients who were screened by nurses, and among them 64 met the screening criteria. However, only 21 patients were alerted, and they were alerted with significant delays, one with some alerted beyond 7 hours, which is actually not that good. And let's see the other secondary outcome related to the documentation of the screening variables. This outcome was analyzed using a statistical process control. What we see here in this plot is the range of non-documented QSOFA variables. Each of the dot points represent non-documented variables during the baseline period, which is before, during the first 12 weeks, and the second 12 weeks represent the intervention period. The cyclic pattern with erratic shifts above and below the central line suggests absence of a statistical control during baseline and intervention periods. Therefore, it is not possible to differentiate changes attributable to the intervention. However, if we can see the overall picture, we see a trend towards the improvement in the documentation of the screening variables. The more neglected observation was altermentation. The other neglected observation, respiratory rate and systolic blood pressure, they were less documented, but the documentation was overall better than the altermentation, which suggests in this particular setting, the assessment of altermentation may be challenging, we don't know, or maybe it could be a problem of the documentation, not on the assessment. Well, this is something to investigate in a further study. And let's see what happened with the adherence to the 6-hour bundle with this implementation. And this outcome was assessed in a second group during the intervention period only in 547 patients. Most of these patients were screened were screened most of the time. And among these patients, 64 met the QSOFA-based sepsis screening tool criteria, which means they had to be alerted for sepsis. And I divided this group of patients in those who were alerted and those who were not alerted. And if we notice the care that these patients receive, there is a similar proportion of patients receiving any element of the 6-hour bundle and other care. That tells us something. There were a small proportion of alerts among these 64 patients who met the screening criteria. However, a similar proportion of patients received care. I will back to this idea close to the conclusions of this study. Finally, excuse me, in regards to the barriers and facilitators and strategies, I assessed the barriers and facilitators. Barriers were interpersonal and team structures, which were some team compositions, the way they were communicating and they were relating within teams that were considered some barriers to the implementation. But there were also facilitators highlighted the value of education and knowledge. Nurses were keen were very receptive to the educational intervention. There were productivity towards high quality of care, which was fantastic, and that helped the adherence to the intervention, and that's why we understand we could sustain the screening assessments during the study period. The implementation strategies that were developed based on the assessment of these barriers and facilitators were the sepsis screening and response guide. We included in a guideline elements of the screening tool and explanation, the evidence, and how to proceed when the patients needed the alert and the response mechanism. Excuse me. And education sessions were conducted. I'm sorry, excuse me. Education sessions were conducted. There were implementation and team rounding. This was useful. The implementation team consisted of physicians, leadership physicians from the intensive care, from the hospital ward, and nursing leaderships as well. The nurse unit manager, the educator was involved, and there were also nurse champions in each shift. And this team were rounding in different nursing shifts to talk about the challenges, how to assess, how to alert, how to communicate if there was clinical deterioration, how to act in response to the deterioration, excuse me, and how to request and communicate with physicians. And that was actually very helpful for supporting nurses during the intervention period. We also have posters. I couldn't get funding to face, for the implementation costs, because, in my country, there are not too many sources of funding for implementation studies. So what we developed with the support of the hospital, we had some very simple black and white printings, and we share the information all in these black and white printings as small posters, and we distributed them in the shifts, audit and feedback with the rate of the screenings conducted and the rate of the patients who were admitted to intensive care. And we provided a feedback on the procedure, number of patients, how we respond, so every nursing team knew what was going on with the patients who had been alerted, and including those who hadn't been alerted as well. And there were also some knowledge brokering strategy. So it was a discussion of sepsis papers for those who were interested, and there were physicians and nurses who were interested, and they say, okay, we would like to have this paper to read that other paper, and we were facilitating during the study period so that information as well. So that was quite a very interesting way to support providing information and education. And to conclude, the tested tool represents the current understanding of the pathophysiology of sepsis, and that is provided by the high specificity of the screening tool, which was close to the 90%. The modest sensitivity may cause some cases to be missed. However, if we compare with other studies, yet there are tools with a greater number of variables with similar sensitivity. And now I'm referring to the ESOFA, for instance, that was very, with modest sensitivity, although it had higher positive predictive value. But also the evidence, there's evidence showing that less sensitive tools, when implemented, resulted in improved provision of treatment. That is a study by Umshid and colleagues, which is a very sophisticated design with implementation component, and they prove to improve the provision of treatment. But the tool was based was based on the QSOFA and the sensitivity on the SIRS, and the sensitivity was quite low for the diagnosis of sepsis, which means sometimes the context is playing an important role over the characteristics of the screening tool. The QSOFA score could help identify patients at risk of developing sepsis during their hospitalization. That is evidentiated and supported by the high predictive validity by the area under the receiving operating characteristics curve. QSOFA screening could be useful where no screening mechanism is in place because it's a very simple tool. 4 variables, including the 3 of the QSOFA plus the infection variable. That is the way we implemented. Infection was part of the screening. One of the questions nurses had to ask themselves when assessing the patient is this patient having an infection? And that is very important because we anticipate even earlier in all patients, when the patient is admitted, is at risk of acquiring a hospital-acquired infection, for instance. Patients with sepsis receive treatment regardless of the alert activation. The similar proportion we found in those alerted and not alerted receiving any treatment first, which means there is a clinical judgment playing an important role on treatment decisions. And it's further research is needed to understand how clinical judgment acts, how is clinical judgment is playing a role on these decisions. Delays in alert activation and provision of treatment needs further research. Particularly, they were paper-based tools, they were not electronic. So perhaps the setting characteristics was posing another challenge to the alert activation. I could have missed some alerts because of nurses did not document that. There were some patients not alerted receiving treatment, so that is highly likely could have happened. It is possible to achieve change in a short period of time, but sustainability needs to be investigated as well. So one is, this was a 1 year of work, 12 weeks baseline and 12 weeks intervention. But if we want to sustain in time, it is necessary to fund that intervention and that support. Unfortunately, I did not have funding to continue with the implementation. But however, with a very low cost, very simple techniques, strategies to support the staff, we could achieve change. So that is also important. If we want change, it is supporting the staff, it is being close to them, providing feedback, and the strategies I have described can be helpful for achieving change. And we need future research to better understand the early recognition of sepsis in settings such as developing nations, because where there are no electronic health records, yet they are slow to arrive in some settings. What tools are suitable for us in different settings than in high-income countries? I think we need to continue asking these research questions in different settings. And this was some picture of the people. This study was conducted with the support of 100 nurses and 50 physicians. We work all together on the implementation of this, and this was a fantastic team. I am so grateful to them and the patients who participated. And the study resulted in 4 publications, the systematic review, and the diagnostic accuracy, which is the sensitivity and specificity of the tool. That was outcomes that results were published in the International Journal of Clinical Practice, in the Quality Journal, the outcomes of the implementation and the description of the implementation in a nursing journal, and preliminary findings were presented at a conference at the ANSICS, at the Australian and New Zealand annual scientific meeting, and it was awarded a Best Nursing Scholarship paper. So that was a fantastic experience for me in my PhD education I had. So I'm happy to share with you today. Thank you for listening to this. And that's the end of this section on screening and implementation on tools. Excuse me. And I want to move and continue with the Surviving Sepsis campaign guidelines and sharing some priorities in sepsis management. I will continue discussing, of course, screening, because that is part of one of the priorities in the early recognition of sepsis, but I will also share some treatment priorities as well. As you know, the guidelines are a joint endeavor between the Society of Critical Care Medicine and the European Society of Intensive Care Medicine, and these were the latest update of the guidelines published in 2021. And I will focus on the early recognition and priorities in early treatment. These guidelines have 93 recommendations across from early resuscitation to long-term outcomes. Let's go first with the recommendations on screening. First, what are the recommendations on sepsis screening? I can't see, excuse me. Yeah, there it is. In relation to the screening and standard operating procedures, the sepsis, the panel recommend using a performance improvement program for sepsis, including sepsis screening for acutely ill high-risk patients and standard operating procedures for treatment. A standard operating procedure would be, for instance, the 6-hour bundle. We know that it was updated and now it's 1-hour bundle, for instance. But the standard operating procedures are included in the guidelines. And why they are recommending, despite this is a strong recommendation with moderate quality of evidence for screening and very low quality of evidence for standard operating procedures. And they are supporting this recommendation on this systematic review and meta-analysis of observational studies where there was researchers have found a positive association between the quality improvement interventions and the compliance with the resuscitation bundle. And the majority of the studies showed a significant decrease in mortality, which means when there is a systematic approach in the quality improvement programs, there is a significant reduction in the mortality for sepsis. So that is why this recommendation is, and this has been improving and improving since the establishment of the Surviving Sepsis campaign in the early 2000s. The sepsis recommendation, the sepsis guidelines recommendations regarding the screening tools in particular, they are recommending against the use of the QSOFA compared with SIRS, NEWS, or MUSE as a single screening tool for sepsis or septic shock. So they recommend against, but with this evidence might be changing. Remember the review of Kumar and colleagues, where we found the QSOFA plus lactate. So the recommendation for using QSOFA as a single screening tool for sepsis, that is recommended against. But research is now improving and evolving, and there may be other variables such as lactate that may be improving the sensitivity of the QSOFA and making a tool to recognize sepsis. We'll see how research evolves. So far, with this evidence, the QSOFA is not recommended as a single screening tool. And SIRS, NEWS, and MUSE are widely used, and there's a lot of evidence on these tools. And this is based regarding the SIRS and QSOFA. This recommendation is based on a meta-analysis of the sensitivity for the diagnosis of sepsis of the performance of QSOFA and SIRS. You can see here in this forest plot for the sensitivity of the diagnosis of sepsis. The evidence favors the performance of SIRS, which means SIRS outperforms QSOFA to help the diagnosis of sepsis. It is more sensitive than QSOFA. We have seen that evidence when we were discussing the Kumar review and the other evidence. But these tools, the other tools, the NEWS and MUSE and QSOFA, have been also used to predict combined outcomes, which are used by researchers as a surrogate of sepsis, because sepsis patients usually have poor outcomes, such as death or ICU transfer. And these tools, NEWS and MUSE, in ward patients and ED patients have demonstrated a good predictive validity as highlighted by the outlook, the area under the curve in these tools. If you can see for the NEWS, which is the one that is performing the best, is close to 0.75, and for the MUSE, it's close to 0.7. Which means these tools are performing very good for the prediction of composite outcomes such as death or ICU transfer. What are the variables that the NEWS and the MUSE are having? These are the tools the sepsis panel is recommended. The NEWS, this is the NEWS 2, it is the latest. The NEWS is one of, as I said before, is one of the most investigated early warning scoring tools. It is a multi-layer. There are several variables. At the latest, which is NEWS 2, also includes an oxygen saturation scale for COPD patients. And the tool is a bit complex because it has several degrees. And if there is no an electronic health alert or technology to help the implementation, doing this in a paper-based manner would be a challenge. I know it has been used in the UK predominantly, but it has also expanded to other countries. But again, electronic health records and technology is required to implement the NEWS. And the early warning score is also another complex set of variables we can see there are similar variables, and that the news, this is also highly investigated, but again, electronic health records and technology would be necessary because implementing this in a paper-based manner would be a challenge. And this leads us to think, what is relevant in a screening tool? And it is important to think about the tool, the characteristics of the tool, which means their sensitivity and specificity are characteristics to consider. It should be sensitive enough not to miss patients with sepsis. It should have a good specificity to help the diagnosis of sepsis, which means if the screening tool results negative when I assess the patient, I should be ruling out sepsis. And that is what the is very important. But should also be useful to predict sepsis diagnosis if they screen positive. And also should help to rule out sepsis if screened negative. So again, the specificity and negative predictive values will be important to consider and be easy to implement across settings. And there, I think here we have one of the greatest challenges when considering screening tools for sepsis. There is a great variation in the resources in the settings. So even in my country, we have facilities with electronic health records, but there is no enough technology, excuse me, to introduce alert mechanisms. So we need a strong research capacity, strong groups who are having statistical skills and technology skills to implement those tools, as well as to support throughout the implementation and to sustain that implementation in time. So that is, I think, very challenging for most low and middle income countries. And that is the first part related to the screening and the evidence on the guidelines. And I want to move now to some core elements of sepsis management, and I will refer to that priorities using the bundle update, the Surviving Sepsis Campaign 2018 bundle update. Well, I will focus here on what are the essentials in the sepsis management. This bundle update is now called the one hour bundle. The previous one was the 6-hour bundle, which I used in my PhD studies, and now this is called the 1 hour bundle. It doesn't mean it should be implemented in 1 hour. It should be initiated within the first hour. The more important elements of this 1 hour bundle are measuring lactate, obtaining cultures prior to the administration of antibiotics, administration of broad spectrum antibiotics. I will go through and share in one of these points some evidence, and within the antibiotics, I will also refer to other antimicrobials. The administration of fluids, and of course, the vasopressors. It is important to note that these are weak, are recommendations, weak best practice statement or strong recommendations, but the overall quality of evidence is moderate to low, which means in the more time pressing sepsis interventions, we have moderate to low quality of evidence. So we will see in the next update of the guidelines the level of where research, if researchers can provide us a greater quality of evidence. But so far is what we have, and it is based on what we had before. Let's have a look to the evidence on lactate. Elevated early lactate, which means at patient's admission, when we are suspecting sepsis, elevated early lactate levels were significantly associated with increased risk of mortality. And this is, we know lactate can be elevated for other conditions different than sepsis. But every time lactate was elevated, the evidence is suggesting that it's associated with poor outcome, regardless of the diagnosis. So that is so important to monitor lactate, particularly if it is elevated at the beginning. And the association of this increased risk of mortality was consistent for cutoff points of 2 millimoles per liter and 4 millimoles per liter. If you refer to the sepsis definition 2016, the definition includes the lactate, for the definition of septic shock, includes lactate of 2 millimoles per liter or greater. And what is the evidence supporting the other interventions that we have in the in this 2018 bundle update? Particularly, I want to refer to the antimicrobials, antibiotics, and cultures. This is a study by Umemura and colleagues in the Japanese context, and they have found that when they investigated the association between mortality and adherence to each of the elements of within the 1 hour bundle, they have found that obtaining blood cultures and administering antibiotics within 1 hour may have been the components most contributing to decrease in hospital mortality. And so this means that antibiotics is a time-sensitive intervention. Cultures are a time-sensitive intervention. And the cultures allows us to identify the infective agent as soon as possible, and also helps in the control of the source of infection. The sepsis guidelines have a recommendation about the timing of the antibiotics. If sepsis is definite or probable, whether shock is present or is absent, the recommendation is to administer antimicrobials immediately, ideally within 1 hour of recognition. If sepsis is possible, and if shock is present, we have a patient deteriorating clinically, and therefore the administration of antimicrobials should be as soon as possible, ideally within 1 hour of recognition. However, if the shock is absent, there should be a rapid assessment of infectious versus non-infectious causes of this acute deterioration. And this also, the recommendations allows us a 3-hour window to administer antimicrobials if the concern for infection persists. That is so important to rule out the infection. The sooner the antibiotics are administered, the better the outcomes. The sepsis panel also recommends, provide recommendations for fungal, for potential fungal and viral infections. For adults with sepsis or septic shock at high risk of fungal infection, the panel suggests using empiric antifungal therapy over no antifungal therapy. Those conditions who are at high risk of fungal infection are listed in the guidelines. I suggest you to, if you can visit them. There's a very detail of evidence of those patients at risk of fungal infection, particularly those with immune compromise. And in adults with sepsis or septic shock at low risk of fungal infection, the panel suggests against using an empiric use of antifungal therapy because there is uncertainty about the risk of the presence of any fungus. And there's no recommendation on the use of antiviral agents. Well, we will see now with the emergence of the pandemic, if we see other recommendations based on the experience we have, because there's a lot of research there were a lot of research on antivirals during during COVID. So we will see with this new iteration of the update of the sepsis guidelines what evidence is coming. I want to refer to the recommendation of source control, the control of the infection source. This is associated with the administration of the antimicrobials. For adults with sepsis or septic shock, the panel recommends rapidly identifying or excluding a specific anatomical diagnosis of the infection that requires emergent source control and implementing any required source control intervention as soon as medically and logistically practical. And that includes the surgical removal of the infection. And it also is recommended, these are best practice recommendations, the removal of intravascular access devices if there is a suspicion that the source of infection are located on these devices. And there is also very important, although a weak recommendation based on very low quality of evidence, but the panel suggests daily assessment for de-escalation of antimicrobials for using fixed duration of therapy, overusing fixed duration of therapy without daily assessment for de-escalation. This is a relevant practice for avoiding antibiotic resistance. I'm sorry, I had the word in my mind, it was on the top of my tongue and I couldn't say it, but it is to avoid antimicrobial resistance. We should give the patient the antibiotics they need. And once we identify the infecting agent and the adequate antimicrobial suited to them, well, we should de-escalate. And that should be a daily assessment practice to think about this clinical decision. And the other recommendation was related to fluids, and I want to say something on fluid management. Here we are. Fluids, the recommendation on fluids are under the section of hemodynamic management, on fluid management. And what I think is important here is the panel is recommending using crystalloids as first line fluid for resuscitation, And they also suggest using balanced crystalloids instead of normal saline for resuscitation. And also suggest using albumin in patients who receive large volume of crystalloids over using crystalloids alone. They favor balanced crystalloids because normal saline solutions may lead to adverse effects. And there's a recommendation against the use of gelatins and starches because there is inconclusive effect on mortality and increased adverse effects and high costs related to the gelatins and a high risk of death and rapid response activation related to the starches. And I think that's very important evidence to consider, although I mean, again, looking at the resources of the settings, there may be some solutions that may not be available in some low and middle income countries. And I think I'm just close to the final. I want to say something on vasopressors. Sorry, here I am. Vasoactive agents, the panel suggests, the sepsis panel suggests the use of norepinephrine as first vasopressor. The target main arterial pressure is 65, and it should be considered the invasive monitoring of arterial blood pressure, so there's more precision in the monitoring of the fluid response. If central line is not possible, of course, consider initiation of vasopressor peripherally. And if main arterial pressure is inadequate despite low to moderate dose of norepinephrine, consider adding vasopressin. And if cardiac dysfunction persists, and with persistent hypoperfusion is present despite the volume status and the blood pressure, there should be dovutamin should be considered. Adding dovutamin or switching to epinephrine. There is a list of vasopressors, and the guidelines suggest, and the evidence supporting one of them, the use of each of these vasopressors are included in the guidelines as well. And norepinephrine provides vasoconstriction with minimal effect on the heart rate. That's why is one of the preferred vasopressor. And these are all the elements. I've focused on all the elements of the 1 hour bundle. There is more information in the Surviving Sepsis campaign website. Each of these strategies should be is recommended to be initiated within 1 hour. That means initiation, not completion, but that may depend on the resources we have. Not every emergency department or hospital ward or intensive care may have the nurse to patient ratios, the physician to patients ratios, and the resources to accomplish these recommendations. That is understandable. And the final slides, I would like to focus on what is needed for future studies. What needs to be studied? What is the optimal model of delivering sepsis care? What is, I'm I'm thinking of this based on my PhD study on implementation of sepsis screening in hospital wards. Some of the lessons I've learned is that implementation is complex. Working for clinicians to change practice is a challenge. It requires a sustained effort. And having a model of care for delivering the sepsis care will depend on the setting, will depend on the resources. But would it be the optimal model of care? We need research in those different settings. If we cannot understand the settings, we cannot understand, we will not know how this sepsis care must be delivered and implemented, engaging the people working in those contexts. What is epidemiology of sepsis, susceptibility, and response to treatment? Well, we don't have even the actual numbers of sepsis epidemiology in some regions of the world. What we know so far is based on the global burden of disease of diseases, and it's that excuse me, that evidence derived from the analysis of the mortality from other diseases, and conclusions were made on the epidemiology of sepsis based on that study. But we actually do not know what is the epidemiology of sepsis in some South American countries, Africa, Southeast Asia, those low and middle income countries. What is the actual burden of sepsis? And we know less about if they are susceptible and how they respond to treatment. The current guidelines, the sepsis guidelines, are informed by evidence from high-income countries. And there is emerging evidence telling us that one size does not fit all, and that evidence, when implemented in other settings, such as the African context, may be harmful. And we need to investigate response to treatment in different populations, and we don't have that evidence yet. What information identifies organ dysfunction? So there are several organs. There's no one indicator that tells us how that organ dysfunction can be identified. That would be very important for the early recognition of the recognition of early signs of sepsis. How can we screen for sepsis in various settings? That is a challenge as well. There are current tools examining different populations with very great variation in sensitivities and specificities. There are scoring tools that are performing very good, such as the Muse. There are others that are evidence that are emerging, such as the Q-SOFA plus lactate, that is improving sensitivity. But what are these tools applicable, easy to implement in different settings? Well, we don't know. How do we identify septic shock? As early as possible. There is emerging evidence on the use of machine learning for the prediction and the use of big data for the prediction of the onset of septic shock. But that has been conducted in high income with a high technology available. Well, how do we identify septic shock in a rural hospital in my country, in Peru, in Bolivia, Colombia, the Caribbean, the Africa, Southeast Asia, in those very remote areas. How do we identify and assist those patients vulnerable to septic shock in those areas? That is another challenge for researchers. What in hospital clinical information is associated with important outcomes in patients with sepsis? We should be evaluating process outcomes, but also process outcomes tells us about how clinicians are providing care to our sepsis patients. But also we need to evaluate long-term outcomes. I haven't said much on long-term outcomes. Well, actually, I think it's an emerging field of research. We are paying attention today to the post-sepsis, the post-ICU syndrome, and the post-sepsis syndrome, which appears to be the same entity according to research, but there are lasting deleterious effects of sepsis that survivors are suffering. What is the quality of life, the cognitive function, the physical function? Are those patients being readmitted? Are they coming back to work? What are the financial or economic loss that we have because of those survivors are not able to go back to work? We don't have numbers of the economic impact, and particularly, again, I say, in low and middle income countries. I think those are pressing needs, pressing public health problems that need to be investigated, as well as, of course, the early recognition of sepsis. To conclude, the body of evidence in sepsis care is increasing, but still we need more robust studies. As we could see in the evidence provided, we have a moderate to low quality of evidence, and for the core, the 1 hour bundle, the 1 hour bundle, we have moderate to low quality of evidence. So we need urgent research investigating on that aspect of the early recognition and treatment. There is a great variation in studies across the world. I've already said that, but despite this great variation, the evidence is growing. Sepsis is a hot topic for research, but we still need more in less resource settings. But above all, these are guidelines. Guidelines are derived from research from high-income countries, and they may not apply to some populations that haven't been investigated. So guidelines are guidelines. They do not replace the clinical judgment. It is our clinical judgment that allows us to understand a clinical situation, identify the clinical deterioration, and act immediately based on our knowledge. Guideline implementation should carefully consider the resources of the setting and individual patient characteristics. And when the evidence is not enough, well, that will come a future research area, but also there's a movement now that advocates for engaging the public and the patients, so we can develop guidelines focus on the best interest of the patients and their families as well. And a final say, I would like to say to conclude, sepsis It's a medical emergency. And we are here today in this World Sepsis Day, learning how to identify early signs and symptoms, how to treat, thinking, examining the best available evidence. But we also we are doing this because we want to be well equipped to look after our patients. But we should act diligently, doing our best, because that patient is not only a patient, that is a father, a mother, a son, a grandpa, a grandma. It can be one of us. And we deserve the best of ourselves. And I hope sharing this information, I contributed to some refreshment and giving you some insights for you to perform and do your best with your patients. And having said that, I thank you for having me, and thank you for giving me this time to share some priorities, concepts and priorities on sepsis management. And I will provide this recording, but I will be on leave for answering questions. Thank you very much. Thank you, and be blessed.
Thank you for that wonderful and very informative presentation, Dr. Alberto. We now invite our participants to participate in our Q&A session. Please type your questions in the chat, and we'll aim to address only two questions due to time constraints. So while waiting for our participant to type in, maybe I'll go ask my first question to Dr. Laura. Dr. Laura, can you recommend any specific strategies for early sepsis detection in a BC healthcare setting?
Oh, that's a very interesting question. If this is in a BC setting, well, I think in a BC setting, you should be asking the clinicians, your doctors and nurses, what do they think it is the best tool, providing the evidence. Let them give the evidence to them, and they will discuss, assess the variables, and say what is best for their patients. And that would be my recommendation.
Thank you for that, Doctor. We're still waiting. Anyone from participants wants to ask any question to Dr. Alberto? Yeah, I guess I can ask one more. Can I? So are there any emerging trends or innovations in sepsis management that you believe hold promise for improving patient outcomes?
While the evidence is emerging, I think there's a lot of the intervention of AI, the analysis of big data. I think mobile solutions will come with echography for assessment, even in rural areas. There are developments there, and I think the future is bright in that aspect. I think technology will help us reach more rural areas. But I think that is coming in the early recognition and also in the diagnostics and assessments in other settings. I think that is promising.
Thank you, Doctor.
I don't want to expand.
Sure.
I know that time limit.
Yeah, so let's just entertain one more question from the participant, coming from Miss Joan Angeles, asking who are the risks for sepsis for the patients, maybe. Yeah.
Oh, yeah. Those who are at risk are those at the extreme age, the little ones, the elders, those who have immune compromise, in those very rural areas, sometimes those who don't have access to vaccination, and those who have a lot of comorbidities, who are prone to new infections, those who had sepsis before, because they have changes in the immune system and in the microbiome, what makes them prone to new infections. While those who have been prolonged longer hospital stays, and those who are institutionalized, like in aged care, age facilities, those who have problems with, I mean, they are recovering from stroke or have problems for, I don't know how to manage saliva. I don't know if deglution is exists in English as an English word. Well, those people are at risk of different infections and therefore sepsis. And of course, the settings where you have multiple bag resistance bags and bacterial resistance, those patients who are exposed, they are also at a high risk of sepsis because they have limited antimicrobial therapy.
Okay, thank you, Dr. Laura. Unfortunately, that's the last question we can accommodate for now. Yeah, so we have reached the end of our Q&A session for this topic. Ladies and gentlemen, we have reached a moment of great significance in our webinar today. It's time to recognize an individual whose contributions have illuminated our visual stage. Our esteemed speaker, Dr. Laura Alberto, has shared invaluable knowledge and insights with us. Today, on behalf of CCNAPI and all of our participants, we are honored to present the Certificate of Appreciation to Professor Laura Alberto as a token of our gratitude. I will now virtually present the certificate to Professor Laura Alberto. Certificate of Appreciation to Dr. Laura Alberto, BNESP ED Master ED, Diploma to Communication Science and PhD for being speaker during online course on World Sepsis 2023, Challenges and Priorities in Sepsis, with the topic Priorities in Sepsis Management, signed by Sir J.C. John Christian M. Agustin, RN, Vice President of CCNAPI, and the President of the World Federation of Critical Care Nurses Association, Adriano Friganovic. Okay.
Thank you. It's been my honor. Thank you.
It's our honor. So thank you, Dr. Laura. I hope to see you again in the future seminars, webinars. Okay. Thank you. So let's proceed with our second topic, which is nursing challenges and pitfalls in sepsis. Ladies and gentlemen, we are privileged to introduce our next distinguished speaker, a remarkable figure in the world of nursing whose multifaceted career has significantly impacted the healthcare landscape. Ma'am Everett Castañares Zafe is a seasoned professional in the field of nursing with a rich and varied background that spans critical areas of healthcare. With a passion for nursing excellence and commitment to ensuring the highest standards of patient care, Ms. Everett's contribution have left an indelible mark on the healthcare community in the Philippines. Educationally, she laid the foundation for her career by earning a Bachelor's of Science in Nursing from Catanduanes State University in 1998. But her pursuit of knowledge and commitment to lifelong learning remain unwavering, as she is currently engaged in ongoing pursuit of master's degree in nursing at the prestigious University of Santo Tomas. Ms. Everett's extensive work of experience reflects her dedication to nursing and her continuous growth in the profession. She has served in various crucial roles throughout her career, including Data Protection Officer, Nursing Director, and Assistant Nursing Director at World City Medical Center, where she currently lends her expertise. Her tenure as an infection control nurse and her time as an ER nurse have equipped her with invaluable insights into the intricacies of patient care safety. Beyond her professional roles, Ma'am Everett is deeply engaged in the nursing community, actively participating in significant events such as Philippine Nursing Association annual conventions, PHEP conventions, and ANSAP conventions. Her contributions extend to her role as a president of the Philippine Nurses Association Zone 3, where she plays a pivotal role in promoting nursing education and professional growth in her region. Her dedication is to the healthcare and nursing is not limited to her work and extends to her role as a board of director in the PNA Chapter 3, Zone 3, underscoring her commitment to elevating nursing profession at both local and national level. Today, Ma'am Everett Castañeda Zape graces our virtual stage to share her expertise in nursing challenges and pitfalls in sepsis. Her extensive background, dedication, and leadership in healthcare promise to enrich our understanding of this critical topic. Please join us in extending a warm virtual welcome to Ma'am Everett Castañeda Zape as we eagerly await her enlightening presentation.
Good morning. My presentation is entitled Nursing Challenges and Pitfalls in Sepsis. First of all, thank you very much to CCNAPI, Critical Care Nurses Association of the Philippines, and World Federation of Critical Care Nurses. Thank you for this invitation. First, I would like to discuss or identify my objectives. One, to explain the role of nurses in sepsis management. Two, to recommend methods in maintaining efficiency and competency of nurses in recognizing sepsis. And third, supply the best practices that will inspire nurses to perform routine assessment in sepsis. Just a little background, at least 1.7 million adults in America develop sepsis. At least 350,000 adults who develop sepsis die during their hospitalization or are discharged to hospice. 1 in 3 people who dies in hospital had sepsis during their hospitalization. So what are the nursing challenges that we have now here in the Philippines? One, long hours have been one of many consistent challenges for nurses. They typically have demanding schedules because nursing is a 24/7, round-the-clock job. These long hours can also mean working overtime, several 12-hour shifts in a row, or being on call. Because nurses' schedules are demanding, working over 40 hours a week is not uncommon. Over time, this can leave nurses feeling drained. Stress and exhaustion, both mental and physical, can be present on secondary challenges in nursing, leading to a potential for costly medical mistakes. Second is a continued shortage of nurses is an ongoing challenge. This contributes to nurses being stretched thin and overworked. For a nurse who takes care of patients seriously, it can be frustrating to not have enough time to devote to each individual patient or interact compassionately with their families. Third, due to the nature of the job, nurses in certain clinical settings can be exposed to dying patients. Their death can evoke a wide range of emotions such as sadness, compassion, and helplessness. It's important for nurses to develop strong coping strategies that can help them prevent compassion fatigue from overwhelming them in a wake of patient's death. Doing so can help them focus on delivering consistent care to every patient they encounter. What is sepsis then? Sepsis is the body's extreme response to an infection. It is a life-threatening medical emergency. Sepsis happens when an infection you already have triggers a chain reaction throughout your body. Most cases of sepsis start before a patient goes to the hospital. Infections can lead to sepsis, most often start in the lung, urinary tract, skin, or gastrointestinal tract. Without timely treatment, sepsis can rapidly lead to tissue damage, organ failure, and death. What causes sepsis? Infections can put you or your loved one at risk for sepsis. When germs get into a person's body, they can cause an infection. If you don't stop that infection, it can cause sepsis. Bacterial infections cause most cases of sepsis. Sepsis can also be a result of other infections, including viral infections such as COVID-19 or influenza or fungal infections. Most people who develop sepsis have at least one underlying medical condition, such as chronic lung disease or a weakened immune system. So, who are at risk? And this is very important that a nurse should know. Anyone can develop sepsis, but some people are of higher risk of sepsis. Adults of 65 years old or older, people with chronic medical conditions such as diabetes, lung disease, cancer, and kidney disease, people who survive sepsis, people with weakened immune systems, people with recent severe illness or hospitalization, and children younger than 1. And these are symptoms, warning symptoms. High heart rate or weak pulse, confusion or disorientation, extreme pain or discomfort, fever, shivering or feeling very cold, shortness of breath, and clammy or sweaty skin. So what are the roles of nurses in sepsis management? Nurses caring for patients in any setting must keep in mind the risk of sepsis and the high mortality rate associated with sepsis, severe sepsis, and septic shock. All invasive procedures must be carried out with aseptic technique after careful hand hygiene. IV fluids, arterial and venous puncture sites, surgical incisions, traumatic wounds, and urinary catheters must be monitored for signs of infections, specifically ventilator-associated pneumonia, as well as actions to prevent pressure ulcers need to be implemented in the care of all patients. Nurses should identify patients who are at particular sepsis or septic shock, keeping in mind that this high-risk patient may not develop typical or classic signs of infection and sepsis. When caring for a patient with septic shock, the nurse collaborates with the other members of the team to identify the site and source of sepsis and the specific organisms involved. The nurse often obtains appropriate specimen for culture and sensitivity. Elevated body temperature is common with sepsis and raises the patient's metabolic rate and oxygen consumption. Fever is one of the body's natural mechanisms for fighting infections. The nurse monitors the patient closely for shivering, which increases oxygen consumption. Efforts to increase comfort are important if the patient experiences fever, chills, or shivering. The nurse administers prescribed IV fluids and medications, including antibiotic agents and vasoactive medications to restore vascular volume. Because of decreased perfusion, serum concentrations of antibiotic agents that are normally cleared by kidneys and liver may increase and produce toxic effects. Therefore, it is inherent that the nurse monitors closely blood levels such as BUN, creatinine, WBC, hemoglobin, platelet coagulation studies. The nurse monitors the hemodynamic status, especially also the fluid and intake and output and nutritional status of a patient. Daily weights and close monitoring of serum albumin and prealbumin levels helps determine the patient's protein requirements. Sepsis is a medical emergency, so as nurses, we should act fast. As recommended by CDC, there are 4 ways to get ahead of sepsis. 1 is to prevent further infections. 2 is to practice good hand hygiene. 3rd, know the symptoms. And 4, act fast. I'd like to share with you the standards on bundles of care. As we all know that patients with sepsis, normally they have a lot of contractions, and we don't want to have more or additional concerns for our patient by not minding the bundles of care. So when we say bundles of care, care bundles are simple sets of evidence-based practices that when implemented collectively improve the reliability of their delivery, and improve patient outcomes. These packages of care contribute to infection prevention, reduce unnecessary antibiotic prescribing, and may limit the development of antibiotic resistance in healthcare facilities. These are the general principles of bundles of care. One is the implementation of care bundles can assist in enhancing compliance to evidence-based quality process measures to improve patient care. Second, care bundles include a set of evidence-based measures that, when implemented together, have shown to produce better outcomes and have a greater impact than that of an isolated implementation of individual measures. Third, bundles also help to create reliable and consistent care systems in hospital settings since they are simple, clear, and concise. In addition to creating safer patient care environments, the implementation of bundles also promotes multidisciplinary collaboration since they should be developed collaboratively and consensus obtained with strong clinician engagement and endorsement. Fourth, in order for bundle implementation to be successful, each element of the bundle must be implemented collectively with complete consistency to achieve the most favorable outcomes, all or none approach. Fifth, the effective implementation of care bundle requires that the measures be adapted to the local setting, appropriately followed, entrenched into the patient's care culture, and recorded and evaluated to ensure compliance of all members of the healthcare team involved. Six, healthcare providers are advised to follow each bundle for its patient always. This aims to develop and promote a positive habit forming behavior among providers and ultimately a reliable care processes. Seventh, bundled interventions are effective way to implement change and to improve the culture of patient safety by promoting teamwork, measuring compliance, and providing feedback and accountability to frontline teams and hospital leadership to improve care. There are four important bundles of care. First is the ventilator-associated pneumonia or VAP, the CAUT or catheter-associated urinary tract infection, CLABSI, central line-associated bloodstream infection. Last but not the least is the SSI or surgical site infections. The most common infections that a sepsis patient can have is a ventilator-associated pneumonia. Ventilator-associated pneumonia is a lung infection that develops in a person who is on a ventilator. A ventilator is a machine that is used to help a patient breathe by giving oxygen through a tube placed in a patient's mouth or nose or through a hole in front of the neck. An infection may occur if germs enter the tube and get into the patient's lungs. In order to prevent having back, the following are recommended. Keep the head of the patient's bed raised around 30 to 45 degrees unless the medical conditions do not allow this to occur. Check the patient's ability to breathe on his or her own every day so that the patient can be taken off from the ventilator as soon as possible. Clean your hands or our hands with soap and water or alcohol-based hand rub before and after touching the patient or the ventilator. Clean the inside of the patient's mouth on a regular basis and clean or replace equipment between use on different patients. So for patients and family members, it's part of our patient and family education to teach them to quit smoking. Patients who smoke get more infections. And of course, as healthcare providers, please clean our hands. Patient and family members, ask them by raising the head of the bed when the patient will be allowed to try breathing on his or her own and clean our hands, especially let's emphasize on the hand hygiene. These are best practices in sustaining bundles of care. There must be an active role of infection control committee in the hospital, and the composition of the committee is multidisciplinary. So when we say multidisciplinary, it is coupled with an institution-wide multimodal strategy, including will building, awareness, training, education, measurement, and feedback, are required to optimally promote and sustain the implementation of care bundles in hospital settings. It is also recommended that there must be a continuous training and awareness among healthcare providers, especially to our nurses who are providing the highest or the higher number of direct cares to our care hours to our patient. An infection control nurse must have really a task or to implement and monitor the daily tasks of infection control committee in terms of prevention and detection of infection through training and awareness, policy making, quality assurance, and auditing. In our hospital, we implemented a lot of monitoring tools, and we do our evaluation on certain time or like in a quarter or in every year, so that we'll have analysis and measure our um, performances for each monitoring, like hand hygiene compliance. There are also infection control checklists for patients with under bundles of care or too many contraptions, and of course, the infection control practices of our nurses and other healthcare providers. We also trained our head nurses to be very acquainted and competent in conducting their surveillance, not only for notifiable diseases, but also the healthcare associated infections. So they serve as our link nurses to our infection control committee. Through this, we can have more and better data and ensure that our patients we are delivering safe and quality patient care. Next is we do our surveillance for healthcare associated infections on monthly basis, and it is being submitted to infection control committee for validation and analysis of our data. We also have our monthly device utilization, healthcare associated surveillance form, and summary of HCAIs per month. It is also important that we'll have a very good hospital antibiogram. This is a periodic summary of antimicrobial susceptibilities of local bacterial isolates submitted to the hospital clinical microbiology laboratory. Antibiograms are often used by clinicians to assess local susceptibility rates as an aid in selecting empiric antibiotic therapy and monitoring resistance trends over time within an institution. Antibiograms can also use to compare susceptibility rates across institutions and track resistance trends. And we use our antimicrobial surveillance form to monitor this compliance. There are also available written protocols, which is very important, especially for nurses and obese nurses. The development of how-to guidelines and the provision of standardized data collection tools that calculate bundle compliance are advised to ensure healthcare team members are clear on the elements of each bundle, the actions required, and how compliance is measured and tracked for feedback. We also have our signages on VAP and ensuring that the standards for prevention for VAP, such as elevate the head for between 30 to 45 degrees, daily oral care with chlorhexidine, interrupt sedation, and assess readiness to extubate. And all of these parameters are posted in strategic areas so that our healthcare providers are reminded. We also have posters for COUT as well as with Club C. Another important thing is the collaboration with admin, finance, purchasing, biomed departments in realizing of having a safe and quality patient care, not only the healthcare providers. So it is really a team effort. And involvement not only by the bedside nurses, but also our nursing officers. So we train our nursing officers and staff to be an advocate what is safe and quality for us to have a better patient outcomes. Whether we are the healthcare providers as nurses, doctors, or from ancillary or from admin, or stakeholders, suppliers from infection control committee, we believe that in caring for a sepsis patient, it takes a village to sustain a bundles of care. I'd like to share with you a new recommendation of CDC, or Center for Disease Prevention. It is called Hospital Sepsis Program, or core elements. Core elements are essential to optimize patient care and help clinician hospitals and health systems in efforts to improve the hospital management and outcomes of sepsis. Hospital Sepsis Program core elements outline structural and procedural components that are associated with multidisciplinary expertise required to support the care of patients with sepsis. This tool provides examples of ways to implement the core elements. The core elements are intended to be adaptable framework that hospital can use to guide efforts to optimize sepsis care. Thus, not all examples listed in the core elements may be necessary and or feasible in all hospitals. So, these are the elements. One is hospital leadership commitment. Second, accountability. Third, multi-professional expertise. Fourth, action. Fifth, tracking. Six is reporting. Last but not the least is about education. So these are examples of the requirements of the core elements. So if you can see, there is a sample checklist, and I just ran down all the important elements of the core elements. First is there must be our program leaders are given sufficient specified time to manage hospital sepsis program. So this will be a great help for all managers and nursing directors also, or medical directors in their own hospital, to utilize the checklist. Our sepsis program is provided sufficient resources, including data analytics, information technology support to operate the program effectively. Third, relevant staff from key clinical groups and support departments in our hospital have sufficient time to contribute to sepsis activities. Our hospital has a senior leader who serves as an executive sponsor for sepsis program. Sepsis has been identified as a hospital priority by hospital leadership, and this priority has been communicated to hospital staff. Our hospital leadership communicates to our hospital staff and patients how our hospital is addressing sepsis. Our hospital leadership has regular meetings with leaders of the sepsis program to assess the resources needed to accomplish the hospital goals for sepsis activities and outcome. Hospital sepsis program activities are integrated into other quality improvement and patient safety efforts, such as emergency department triage, antimicrobial stewardship, transition of care, centers for Medicare services, septic shock management, bundles reporting. Our hospital staff performance incentives are tied to the achievement of targets of sepsis care and or outcomes. Sepsis program-related duties are included in job description or performance reviews of our hospital sepsis program leaders and key support staff. Hospital leadership supports external training and education for sepsis program leaders and key support staff. This is for quality improvement trainings and attendance at sepsis meetings. Our hospital leadership supports internal training and education on sepsis for hospital staff and trainees. Hospital leadership supports participation in regional, national, and international sepsis quality improvement collaborative and initiatives. Another is our hospital has a program or committee in charge with monitoring and improving sepsis and or outcomes. And there is one leader or two co-leaders, physician or a nurse responsible for sepsis program or community management outcomes. Our hospital sets ambitious but achievable goals for improving sepsis care and patient outcomes that are informed by review of hospital practices, hospital sepsis outcomes, and clinical practice guidelines. Hospital assesses progress towards hospital sepsis goal at regular intervals and updates goal periodically to promote continual improvement. Hospital has one physician and one nurse lead or champion to ensure physician and nursing engagement in the sepsis program. Sepsis program related activities and outcomes are included in annual performance reviews for sepsis program leaders. Hospital has unit level physician and nurse champion for sepsis activities. Sepsis program activities and outcomes are reported to senior hospital leadership and hospital board of directors on regular basis. Hospital has a sepsis coordinator who oversees day-to-day implementation of sepsis program activities. Clinicians and leaders from emergency department, inpatient wards, and intensive care units are fully engaged in the hospital sepsis program activities. Hospital sepsis program includes diverse multidisciplinary representation, for example, antimicrobial stewardship, critical care, emergency medicine, hospital medicine, infectious disease, nursing and primary services, surgery, oncology, obstetrics, pediatrics, pharmacy, and social work. Hospital sepsis program has an ongoing support from individuals with expertise and formal training in data management and analytics, information technology, quality improvement, and patient safety. Hospital sepsis program has at least ad hoc involvement of case management, microbiology, laboratory medicine, phlebotomy, outpatient clinicians, hospital epidemiologists, infection preventionists, patients' families, caregivers, and community members. Hospital has implemented a standard process for sepsis on presentation and throughout the hospital. And the hospital has a guideline or a standard care for pathway for management of sepsis that addresses screening, clinical evaluation, diagnosis, antimicrobial selection, source control, fluid resuscitation indications for treatment escalation, antimicrobial use, patient and family caregiver education, and peri-discharge management. Hospital has order sets for management of sepsis tailored to patient population served. Our hospital has structures and processes in place to facilitate prompt delivery of antimicrobial, including stocking of common antimicrobials in locations outside the pharmacy, immediate processing of new antimicrobial orders, clinician order entry systems that default to immediate administration of antimicrobials, and pharmacies on site in key locations outside the pharmacy. Hospital has structures and processes in place to support effective handoffs of patient with sepsis, such as templated notes to document sepsis diagnosis and treatment information. There must be also a hospital rapid response team who is trained in sepsis recognition and care. And it is also recommended that a hospital should have a code sepsis protocol for facilitating prompt recognition and team-based care of sepsis. It is also recommended as a hospital to complete peri-discharge evaluation of patient after sepsis to screen for new or worsening functional limitations, cognitive impairment, post-traumatic stress disorder, anxiety symptoms, and chronic health conditions. The hospital completes peri-discharge evaluation of patient through screening for new worsening functional limitations, cognitive impairment, anxiety and chronic health conditions, provides post-discharge care coordination and anticipatory guidance designed to optimize recovery from sepsis, and prevention of healthcare-associated infections and hospital-onset sepsis that may follow facility based on infection control or prevention recommendations. Also, hospital monitors hospital sepsis epidemiology, such as number of hospitalizations with community onset sepsis, hospital onset sepsis, and septic shock. Hospital monitors hospital sepsis management, such as time to antibiotic delivery and time from antibiotic order to antibiotic delivery. Our hospital monitors progress towards achieving goals for sepsis management or outcomes, completes near real-time chart reviews for purpose of clinician feedback and education, and also chart reviews regularly for the purpose of root cause analysis and process involvement. It is also recommended that hospital report sepsis treatment and outcome for nursing, physician, unit-based, and hospital leadership at routine intervals. And there must be a data on unit-level data, trends over time, comparative or benchmark data. And also, hospital provides feedback to individual clinicians regarding the care of recent patients with sepsis. A hospital must have and maintain also a live dashboard to report sepsis treatment and outcome in real time, and provides feedback to individual clinicians regarding the care of recent patients with sepsis, and maintain a real-time dashboard. Another thing is there must be a specific training and education in hiring or onboarding process for healthcare staff and trainees, and provides annual sepsis education to clinical staff, and written and verbal sepsis education to families, patients, and or caregivers prior to discharge. A hospital posts information on recognition of sepsis in prominent areas for patient-facing staff attached to a vital sign machine or in a staff break rooms. And hospital holds lectures or an annual meeting focused on sepsis, and hospital includes sepsis recognition and treatment in annual nursing competencies, which can be also integrated in the nursing job description, and identification of their core competencies through their performance evaluation form. So in conclusion, I know that we have a very good, a very big challenge in terms of number of manpower of nurses in the Philippines and globally. But there are standards that we need to implement so that we can achieve a safe and quality patient care. And as a nursing leader, I would like to convey this message in conclusion, that it takes a strong voice and determination to implement safe and quality patient care. And I always believe that it takes a village to take care of our patients, especially our patients with sepsis. According to Jean Watson, caring is the essence of nursing. But for me, while we are into technical advancement or technological advancement, and we have advancement also in protocols in caring for sepsis, nothing will beat or surmount the caring presence of a qualified or a competent nurse at the bedside caring for a patient with sepsis. With that, thank you very much and good morning.
Thank you, Ma'am Everett Zafe, for that insightful presentation on nursing challenges and pitfalls in sepsis. We will now move on to the Q&A session where you, our esteemed participants, have the opportunity to ask questions and engage in a discussion with Ma'am Everett. Please feel free to type your questions in the chat and we will address them in order they are received. Okay, so I guess while waiting for participants to chat, to type in their questions to chat, I'll ask the first question to Ma'am Everett. Ma'am Everett, how do you ensure effective communication and coordination among the healthcare team in sepsis management to avoid the pitfalls?
Okay, thank you for that question, sir. We make sure that we have a very good handoff, especially on every shift that we do. We conduct handoffs with different areas, especially patients with sepsis. And in our organization, not only the handoffs, but even our nursing leaders are also involved in the endorsement. Um, Even our supervisors are monitoring for all the requirements of a patient so that we can deliver safe and quality patient care. And even myself as a nursing director, I make sure that I read all the handoffs and results of handoffs and 24-hour endorsement from our supervisor. And I also make sure that we have open communication with our doctors
Thank
and
you, Ma'am
other
Everett.
healthcare providers.
Okay. Yeah. So, okay. I guess anyone from participants curious to want to ask any question to Ma'am Everett? I guess I can ask one more to you, Ma'am Everett. Uh, are there technological advancements or tools that have been proven helpful in mitigating nursing challenges and improving sepsis outcomes, Ma'am Everett?
We in our practice, yes, we as I relayed this morning, it is very important that we have a very good or stable infection control, prevention and control standards within the hospital. That includes the antimicrobial use, nurse-patient ratio, very important. Um, and of course the checklist for bundles of care. However, the biggest challenge now is really the staffing on how we can not only the in terms of quantity of nurses, but also the level of competency of nurses, because since there is a certain move from of Filipino nurses going abroad, most of the nurses left in the Philippines are novice nurses. So the challenge is on how to train them in the fastest way and to have that clinical eye in the fastest way, guided by their senior nurses.
That's wonderful, Ma'am Everett. So yeah, um, I guess anyone from participants? Okay, so no one in participants are asking their questions. I guess another another question from me, Ma'am Everett. I hope you're okay.
Okay, okay.
Okay, so can you share any strategies for overcoming the challenges associated with sepsis recognition in a busy clinical setting, Ma'am Everett?
Challenges in terms of there are many challenges like in an ICU setup or in a tertiary hospital catering a lot of different patients. One is if you have novice nurses, then they have to be really acquainted on how to be alerted for symptoms of patients having sepsis or initial sepsis. Um, I think that's part of my presentation that I
Yeah.
mentioned that we have to act fast. So that is one challenge. But that can be, I am a kind of a person that I always have this mindset that in every problem there is a solution. That's why intensive trainings are being provided to our um, nurses, not only in their technical competence, but also on their soft skills. Um, so these are important things that to recognize and at the same time put solutions so that we can, deliver the best really care for our patients with sepsis. So the most important thing is we know what we are doing as a nurse, and we'll have to hone our new nurses, and even our senior nurses must have continual improvements too. So there are also nursing care audits that are being done so that we can identify areas for improvement and things that we need to improve on the bedside. We also encourage feedback from our doctors and other ancillary group, and post conferences are important so that you can cite better way of taking care of our patients with sepsis.
Okay, thank you, ma'am. Yeah, so we have one question from participant. What is the ideal nurse-patient ratio to be follow or implement to these guidelines? And
Okay.
I guess we want to emphasize the ideal versus the local standards, ma'am.
Okay. With local standards, we are required for in the ward, one for level 1 and level 2 patients, we have a ratio of 1 nurse to 12 patients. However, if the patient is with sepsis and with contraptions that can be elevated to level 3 and 4, it has to be, if it's in a critical condition, and if the patient is in the ICU for monitoring and not intubated, the requirement is at least 1:3, 1 nurse into the 3 patients. But if patient has more contraptions and intubated and closely monitoring, I guess the best ratio is 1 nurse into 1 patients. And we even provide more nurses to attend, because it depends on the clinical presentation of the patient. If there are other comorbids, then therefore 1:1 nurse, 1 nurse to 1 patient is not enough. We can adjust in our staffing. That's my recommendation.
Oh, nice. So yeah, I guess the ones asking is a foreigner from Miss
Yeah.
Kuruva. I guess you can. Okay, so yeah, I think she's satisfied.
Yeah. Thank you.
So thank you, Ma'am Everett. So let's proceed with the next portion of our webinar. Ladies and gentlemen, as we move forward in our webinar, it is our privilege to take a moment to express our heartfelt appreciation to profound insights we have gained from our distinguished speaker, Ma'am Everett Zafe. On behalf of Critical Care Nurses Association of the Philippines, in collaboration with World Federation of Critical Care Nurses, awards this certificate of appreciation to Everett Castañeda Zape RN for being our speaker during the online course on World Sepsis Day 2023, Challenges and Priorities in Sepsis, with the topic Nursing Challenges and Pitfalls in Sepsis. Signed, John Christian Agustin, Vice President of CCNAPI, and Adriano Friganovic, President of WFCCN. Please accept.
Thank you. Thank you. It's always been an honor to be a part of CCNP and World Federation of Critical Care Nurses.
Thank you, Ma'am Everett. And congratulations on receiving this certificate
Thank
of
you.
appreciation. Your impact on our webinar has been immeasurable. Okay. As we continue with our webinar, we carry with us the valuable insights you have shared today. So we will now transition to the next segment of our webinar. Thank you for As we approach the closing ceremonies, let's reflect on the knowledge shared and connections made, our speakers, moderator, and your active engagement to have made this webinar a success. Let's celebrate our journey in critical care nursing. Look forward to future opportunities and growth and collaboration. So for our closing ceremony, let us call on Ma'am Maria Sebelita Sirogado Man RN, the president of our Critical Care Nurses Association in the Philippines.
Hello, good afternoon to everyone. On behalf of the World Federation of Critical Care Nurses and the Critical Care Nurses of the Philippines, we hope that you have learned something from our celebration today, which is the World Sepsis Day. And I hope that you have understood how serious the problem is when the patient will be diagnosed with sepsis or will go into sepsis. So it is very important that we understand the principles that is guiding us in our practice to identify early the signs and symptoms of sepsis. So thank you very much for your attention and for patronizing the webinar sponsored by CCNAPI and the WFCCN. Thank you.
Thank you, Ma'am Rogado, for that wonderful speech, closing ceremony. Okay. So that again, to remind everyone, this webinar is applied for CPD credit units to the PRC Board of Nursing. World Sepsis Day 2023 challenges in and priorities in sepsis for 4 units. Well, status still pending. You'll receive a certificate with your name. However, on this our encircled part, it will be left blank. But our team will send you the follow-up email for that once accepted or approved. Okay, next, ma'am. For the reminders and upcoming courses of CCNAPI. Next, ma'am. So on September 14 and 15, that will be this Thursday and Friday, there will be a webinar about nursing documentation brought to you by or provided by Advanced Clinical Laboratory for Skills and Healthcare Solutions. The topics would be the Joint Commission Standard in Documentation and Record Management, Healthcare Information Security, HIPAA and the Philippine Data Privacy Act, documentation format, patient safety goals, concepts of legally defensible charting. So to register, you may scan the QR code. For inquiries, you may contact the following number here posted. Also on September 19, 20, and 21, that's a 3-day basic EKG rhythm interpretation brought to you by Critical Care Nurses Association of the Philippines and Advanced Clinical Laboratory for Skills and Healthcare Solution. So the objectives are to understand the electrophysiology of common cardiac rhythms, gain confidence in interpreting dysrhythmias, build preparatory know-how for ACLS certification. You may scan the QR code if you are interested. So there are only limited slots. The contact numbers are here for you to register as well. There is also going to be a at September 25th, Monday, 2023, there will be a webinar about moving towards quality education through appropriate curriculum mapping and revisions, brought to you by Advanced Clinical Laboratory Skills and Healthcare Solution. So here's the QR code. It is only limited to 100 participants only. Okay. At September 29, 2023, it's going to be around 1 p.m. to 5 p.m. There will be a World Heart Day 2023, a nurse's role in acute coronary syndrome, brought to you by CCNAPI. It is a free registration for CCNAPI members. So if you're interested in being a member of CCNAPI, here's the following details after this slide. Yeah. So on November 7, there will be a 5-day training about essentials of critical care nursing, or ECN, brought to you by CCNAPI. Registration fee is here on the screen. You may scan if your institution is interested to register or train the nurses for ICU. Here at the screen, we have our CCNAPI membership. You can register or be a member. Just follow this link. This is the ccnapi.org/membership. So the benefits are you'll have a e-card, which is there's a 1-year membership validity opportunity to network with other institutions, both national and international. Of course, we have WFCC in here. We can avail discounted registration rate at for CPD trainings and conferences. There are free webinars exclusive to members only, like we have presented earlier. Opportunity to participate to the certification courses offered by CCNAPI in collaboration with its international affiliated organizations. Also, career opportunities through linkages nationally and internationally. Members have to have an opportunity to serve the public through community reach out programs. So yeah, you will see a e-card just as shown in the screen. So you may, and yeah, you can contact us here with this number. Okay. So to receive your certificate of attendance, simply scan the QR code on your screen. It will lead you to a link where you can complete both evaluation and post-test. Your feedback is valuable and post-test ensures understanding. Once done, your certificate will be emailed to you. So the link is also sent below the chat boxes. So for other information and concerns, you may please feel free to email ccnapi at this email address. So just email ccnapi ccnapicpd@gmail.com for concerns. Thank you. Thank you and have a nice day. I hope you have enjoyed our webinar today. And please spread the word of our day today. Thank you everyone and have a nice day.